gene and the end of the other gene actually. So that is what is the comprehensiveness means. So we'll go through the slides and understand more about it. So we understand that the basics, the cancer is a disease of the genome and alterations is the key. And identifying these alterations gives answers sometimes to treatment, sometimes to prognosis, and sometimes to diagnostics also. So these three key information can be gathered from the genetic alterations, what we can read through all these techniques. Human genome is approximately 40,000 genes, but established ones are 25,000 genes, and few hundreds of them are known to be involved in cancer, not many. And out of them, approximately 400 to 500 genes have been well studied and are quite implicated in the tumor genesis. And the type of alterations, what we should all know about, can be categorized into four categories. That is, one is the copy number alterations, where the gene may be multiplied into multiple copies, like in this scenario, where we see an example we all know is HER2 new amplification, and substitution, where the gene has been substituted by a new genetic sequence that is called substitution. And then we have insertions and sometimes deletions, where a new gene has been added or a gene has been deleted. So these are the insertions and deletions, and we call them in a short form called indels. In for insertions and del for deletions. And then rearrangements, where the gene being translocated and new fusion genes happen, which will come up with a new protein with a novel function. So these four different alterations can be the key categories, and which needs different technologies in the past to understand what is happening and where it is exactly happening. So in terms of the techniques, we all know that IHC, FISH, and PCR is already into clinical practice, and the newer thing, that is the NGS hotspot, which is commonly available in India these days. And the new topic what we are discussing is the comprehensive genomic profiling, which is sequencing the whole end-to-end gene of interest. And then there are certain things which we call as whole genome sequencing, where all the genome, including the intron as well as the exons of all the genes, are being sequenced. And this is basically used mainly for the research purposes when we are trying to do like a fishing expedition kind of a scenario, where we do not know what to target and understand. But in the comprehensive genome profiling, the number of genes are limited, but end-to-end answers. In NGS, the number of genes are further limited, but limited to few hotspot areas of analysis. So I think this is the example where I have shown a gene from this end to this end, and there are multiple exons in the blue colors, and then there are multiple introns in between. So if you were to do a hotspot analysis, the hotspot alterations or the hotspot areas will be read by the hotspot sequencing methods, which will be picking up the alterations, but they may miss something in between, whether it is the intronic areas or sometimes importantly in the exonic areas also. On the other hand, when you use a comprehensive sequencing approach, it starts reading from the intron-exon boundary of this gene till the end of the exon-intron boundary. So it covers everything what is there in the gene, whether it is at the intronic level or at the exonic level. So hotspot in the comprehensive genome profiling, as I just mentioned, that it's a different technology altogether, where to enhance the sensitivity of these tests, there are certain methods, what we call as hybrid capture methods, which are able to pick up the alterations at a high sensitive rate. And then once they are being enriched, the sequencing gives very robust data and with a lot of confidence in terms of the picking up the alterations. In NGS also, if you were to ask the laboratories what type of method they use, a few of them use enrichment methods which are called PCR-based next generation sequencing, and the foundation particularly emphasized in using hybrid capture-based NGS. And if you see the pattern of the data coming out of the sequencing, is that they do cover end-to-end, like what we are trying to share right with you. But sometimes if they tend to miss, there is a big, you can say, gaps which cannot be filled. On the other hand, the habit capture based NGS, the probes are designed in such a way there's always an overlap. If there's a miss, it will be picked up by the other probes, and then the amount of information missed is far less as compared to the PCR based amplification or enrichment. As we understand the PCR based amplification, they use a forward primer and a reverse primer, and a particular gene of interest or the area of interest is amplified, and then sequencing happens. So this is more of a technical information which we are not dwelling more, but this is a basic thing which everybody should be familiar with, that habit capture based assay is relatively superior in terms of sensitivity and specificity at the same time. So the NGS technologies sometimes needs a lot of bioinformatics pipeline, and large deletions can be also picked up if the bioinformatics pipelines are great. And FMI tends to be, that is foundation medicine industry, tends to be able to pick up large deletions as well. So this is the example where this big gaps of large deletions can be picked up by the FMI. So also in terms of the fusions, the FMI technology or the bioinformatics can pick up not only the partners, not only the fusions, but also the various partners and the various break points, locations or loci, which can also predict various responses to various drugs actually. So having said that, the comprehensive genome profiling offered by Foundation picks up all the alterations, that is the substitutions, the copy number alterations, the insertions and deletions, as well as the translocation. So that is the beauty of one test giving all the information, and you don't need not to go for individual tests like IHC, FISH, or PCR for each different type of alteration. The sensitivity is also very high. For base substitution, it is in the range of 99. Similarly, for indels, it is 98. For copy number of more than 88 copies per cell, it is 95%. And for gene fusion, which is the trickiest one, it is in the range of 90%. So for us, this percentage is very important. And if you see, the positive predictive value is always 99%. So it gives a lot of confidence that yes, we are using the right test for our patients and we are not missing any such information. This kind of data is very much important to know before we order a test, because we are relying on this test to make a clinical judgment here. And if the test has not been validated robustly, you may have a big miss, and which may be detrimental for the patient treatment or the overall outcome. So in terms of comparing the clinically available hotspot test assays, comprehensive genome profiling has shown to be superior. And this is the data from various publications which talks about that it can pick up 17% times more EGFR alterations as compared to the hotspot. And especially for the HER2 alterations, 15% times it can pick up more than the FISH in the breast cancer. And similarly, 26% of the lung cancer genes can be picked up more as compared to the hotspot. And interestingly, 35% of the ALK fusions can be picked up more as compared to the gold standard FISH in lung cancer. So this kind of information is very important for all of us, that yes, we are able to find more clinically relevant information just by using the right test. So how does this apply in different cancer subtypes? Let us give some examples. This is the data coming from a couple of publications where they have analyzed big number of lung cancer cases. And they have identified that exon 19 deletions, 22% of them were false negative with the standard of care testing, that is the ARMS PCR, but were able to pick up on the comprehensive genome profiling. In a similar study, again with big number, also were able to pick up more 21% of the cases which were negative or false negative to be precise with the standard of care testing. So practically 1/5 of the patients may get additional benefit even if your test of ARMS PCR for EGFR tends to be negative. So this is a very important observation. And similarly for ALK, which I have just shared with you, 35%, 1/3 approximately, will be false negative by the standard FISH. And again, the clinical utility of this detection is reflected in the response seen in these patients in up to 78% cases, that these alterations were true positive in nature in terms of picking the right alteration. And this is the clinical benefit the patient may get out of it. So besides the standard known alterations, the comprehensive genome profiling give you information outside the hotspot data and can pick up rare alterations like rare translocation, which is being shown here, like SOX ALK translocation or CD74 ROS1 fusions, and other rare alterations in the EGFR.
And everybody was so happy to meet me.
I think I can hear some voices. Can we mute? Hello. Yeah. So thank you. So the important information coming out of this analysis is that these are all wild type non-small cell lung cancer by the standard of care testing, and were picked up with various novel alterations which have some implications in the therapy, in primarily either in response to the TKIs or resistance to the TKIs at the same time. To give you an example, for a lung cancer case, the patient of metastatic lung cancer underwent COBAS EGFR testing and FISH for ALK testing, and an NGS was also done, and PDL was also carried out for the patient. And the report from one lab came out to be exon 18 C719X alteration in the EGFR with ALK to be negative on the FISH, and PD-L1 was 10% positive from one lab. And the other lab for the same patient gave EGFR negative report with TMB of 19.7, quite high. And there was, again, ALK was negative. So there was discordance in terms of the EGFR report. And this report did not talk about the TMB. And just to mention, it was the hotspot test, and this was the standard of care COBAS EGFR and the ALK FISH. So the patient, eventually we had a dilemma, and the patient was discussed the option of either using TKI based on one report and the use of immunotherapy based on the other report. So eventually the foundation was carried out, and the patient have EGFR alteration, that is G719S. But besides this alteration, the patient also had EGFR 709 as well as 714 alterations. So this reflects a complex EGFR alteration, which may have a different outcome as compared to a standard EGFR alteration. And the TMB in this case was low, not high. And we all should be familiar with the fact that TMB is a mathematical calculation done by the softwares or the in silico calculations. And it is normally done on a data of more than 1 GB data coming out of the analysis or the sequencing data. When you do a hotspot assay, the data is very low. It may range between 0.3 GB to 0.5 GB. And this extrapolated to calculate the TMB, which is not that accurate. To summarize that, the TMB has to be reported with the minimum data of 1.1 GB to be precise, and which foundation is currently being offering currently, and gives a lot of confidence in terms of response to immunotherapy if the TMB is high in this case. So, this kind of challenges are sometimes simplified by a robust assay, which we are discussing here. So let's give an example of a colorectal cancer. Colorectal cancers, we know that they are harboring RAS and RAF pathway mutations. And this paper, which talked about up to 62% of them have RAS and RAF pathway alteration. But when the comprehensive genomic profiling was carried out, they were able to identify almost 10% of the KRAS to be outside the codon 12 and 13. So this additional information, which may have implications in the choice of your treatment, especially the cetuximab or panitumumab, and resistance to these drugs can be picked up. So one time the patient may have additional benefit of going with this particular test and getting no response to these therapies. Similarly, comprehensive genome profiling can pick up RAS amplification, which is quite a rare alteration though, but this can be seen in up to 1.5% of the cases and can behave in a similar fashion like RAS alterations and resistance to these EGFR maps actually. And you can see in this particular bar diagram, patients may have RAS amplification starting from copy number, which is around 6 to 9 and 10 to 19, and then more than 20. So approximately 0.6% of the patient had copy number of more than 20, where you can be sure that the patient will not benefit of the anti-EGFR therapy. And these patients will tend to have the standard of care testing KRAS to be wild type. So we also know that the BRAF 600E, which is the standard of care testing for all of the colorectal cancers, but patients who carry out non-V600E tend to behave in a similar fashion with the BRAF 600E alteration, V600E alteration, with the response rate very similar. So this non-BRAF or BRAF non-V600E alterations will not be picked up by standard of care testing, which can be only picked up by the comprehensive genomic profiling. So this is the additional information what we normally get with all these investigations. So various data sets have been published, whether it is a meta-analysis of 570 phase 2 trials with almost 32,000 patients, suggests that NGS-based genomic profiling gives you better treatment outcome, whether it is a response rate or a PFS or OS. And this is quite significant. And it has been published by various authors into various big journals, whether it is a phase 1 or phase 2 data or phase 3 data. And it's a big number of patients what they have recruited. And you can see that the patient may benefit in terms of overall survival, progression-free survival, as well as response rate if they use the target therapies based on the biomarkers selected based on this genomic profiling. So this is the crux here, that this have given us a lot of confidence. Now the only catch here is how to identify what patient will benefit with which drug. That is the challenge. So now the recent data has come up, and these are prospective trials called IPRIC trial, where the molecular matching has been recommended. And these molecular matching are not single gene and single therapies, but multiple genetic alterations and combination of multiple therapies. And this is these decisions are being made by the molecular tumor board. And the data, you can see that the molecular matching rate was seen in up to 50% of the cases, and the patient who were matched with the right therapy had the response, you can say, in the range of 33% as compared to non-matching patients. That is almost 3 times patient had the clinical benefit, and the PFS was just twice, and the OS was not reached. And so these therapy combinations are very novel, which is being decided by the molecular tumor board. Like nivolumab is combined with trametinib, lenvatinib is combined with the IO, and the combination of Debra, Trametinib, and Cetuximab, and again combination of fulvestrant, everolimus, palbociclib, and pazopanib. So all these rare alterations are being discussed in the tumor board, and then this study was carried out, and this combination showed a superior response rate as compared to the conventional monotherapy approaches. So people are evolving how to use the genomic signatures for their decision making. A real world data also showed, which was published in the Nature last year by Shumai Kato, and he have shown that the patient where the matching score was high showed good benefit in terms of the PFS as well as the OS as compared to the patient who did not match with any drug or the genomic alteration match with any drug. And higher the matching score, the better is the PFS in this scenario. If the matching score is more than 75%, the response rate or the PFS and the OS both are quite substantially better. So another interesting trial, which is a CATCH trial, which is a prospective trial, where they have analyzed the metastatic or advanced breast cancer cases, and they have put all the genomic alterations to be discussed in the multidisciplinary molecular tumor board, and the treatment based on that, whether depending upon the different alterations in the different genes, different category of drugs being offered to the patient. And you can see that the patient had 40% of the patient had stable disease or partial response, and 30% of the patients showed improvement in the PFS of at least 30% while based on the recommendation made by the molecular tumor board. So the significance of this particular prospective trial is giving a new paradigm how to practice genomic medicine actually. And the way we perceive the response, this is a very interesting phenomena which is called PFS2 by PFS1. So anything which gives you a benefit of more than 1.3 is considered to be significant, and this is a very interesting, you can say, concept of evaluating the treatment responses based on the genomic or genomic alterations in the targeted agents given thereafter. So I'm just sharing my experience, which is not yet published, but we have almost more than 200 patients of the comprehensive genome profiling, and I'm just showing a subset of analysis. So this is a subset of 54 patients where we have did or almost all different types of cancers, and all of them were metastatic or advanced or relapsed refractory cases. And what we found that the alterations in 54 patients, where the genes, we found that there was 123 genes which were found to be altered, and 5 were common, and 22 were 5 were most common, and 22 were common altered genes. And the important observation what we had, the patient had point mutations, copy number alterations, indels, gene rearrangement, and splice site variations also. So all these alterations were picked up by the comprehensive profiling. And this is the data of different genes, which were the most common altered genes. And if you see very closely, P53 is known to be the most common altered gene, which we all know about. It was seen in up to 50% of the cases. But the other altered genes like CDK4 and CDKN2AB loss, which was picked up quite significantly. And these two important alterations are actionable in terms of giving some treatment options to the patient beyond the conventional treatment. And this is taken together, all the cancers taken together. And again, this is the classification of the alterations of common mutated genes and then uncommon and the rarely mutated genes actually. So in terms of the benefit, what we got when we analyzed this data, that patient, we were able to find 35 actionable genes. And in terms of the patient, we got that 76% of the patient were having some or the other alterations, which were actionable in nature. So practically, out of every 4 patients, 3 of the patients will have some or the other alterations where you may give therapy which are approved by the FDA in the same indication, or approved by the FDA in other indications. So this is the beauty of a robust test, which gives you a lot of opportunity to treat beyond the conventional and give you some answers, especially in the scenario when the patient is failing or refractory to your conventional first, second, and third line of treatment activity. So some clinical cases to quickly summarize the whole idea. This is a young gentleman who had a family history of mother who had C endometrium and maternal grandmother who had CA of unknown origin. Was diagnosed with CA descending colon, underwent left hemicolectomy with colocolic anastomosis. And the patient had, it was polydifferentiated carcinoma, but no lymph node involvement and no LVI. And so the patient was classed as stage 2. MSI was high, and the patient MSI status showed 3 out of 5 markers showed instability. So no adjuvant treatment was given as per the guidelines, and the patient did okay. But after 18 months, the patient had recurrence, given FOLFOX, second recurrence, given FOLFIRI, and the patient progressed eventually with KRAS and RAS all were wild type, and cetuximab was started. Again, the patient had progression, even with the combination of FOLFIRI and cetuximab. The patient foundation test was sent, and it was the year 2015 when most of us were learning how to use genomic alterations. And these were the alterations picked up in this patient's tumor actually. So BRCA1, BRCA2, MSH2, ATM, and then importantly, we had 50. So there were so many alterations which were seems to be actionable. But when we went closer, the patient had MSI high and TMB was also high. So during that time, we did not have the answers to whether to use the immunotherapy in these scenarios, especially when the TMB is high in colorectal cancer. But recently, and then thereafter, in the next year, the approval came for using a pembrolizumab in second-line therapies when the MSI is high. That was year 2016. So, but we gave the patient immunotherapy, and the patient did well, but eventually succumbed of the disease because of the big disease burden. To give you the gist of the whole idea that early we start involving all these things, when the tumor burden is less, patients have more, you can say, better performance status, you may get the benefit out of it. And similarly, we had a lady with ovarian carcinoma who had a standard treatment, the NACT followed by surgery, had a recurrence, again given Lipodox carboplatin. While the patient was receiving chemotherapy, the patient developed invasive lobular carcinoma of breast, underwent MRM, which was ER/PR positive, 8 on 8, and HER2 negative. As the patient had double malignancy, we investigated by BRCA1 and BRCA2 gene, which came out to be negative. But when the somatic analysis was carried out using foundation, we hit alteration in the ERBB2, that is the HER2 gene, with alteration which was V777L, and this alteration was in the kinase domain. And based on this alteration, it was a big question, should we treat or not with the anti-HER2 therapy? But this V777L was well studied in the various ductal carcinomas as well as lobular carcinoma, and the patient was given Herceptin as an adjuvant treatment based on the somatic mutation of the kinase domain of the HER2 gene. And patient did pretty well for 5 years. And then eventually she had relapsed and failed multiple lines of chemotherapy thereafter, and patients succumbed to the disease. But so this is something what we try to offer the patients beyond the conventional treatment. And this is, every case is a new case, and every case may have some similarity with the previous case, but it has to be discussed like a new book altogether. And you may not get the similar alterations or similar answers for many of your patients, so it becomes quite challenging. More you do, more the confidence you build in, built in, and you become confident while expressing yourself to the patients at the same time. So with that, I will just close the presentation and over to the organizers to follow up with the next set of discussions. Thank you.
Thank you, Dr. Amit, for that excellent coverage. I think it was a very good overview of the ways in which things are happening and things how things will be in the future. So, any questions from anybody?
Yeah, I have a question. Just hello.
Yeah. No.
So I just wanted to ask you about this hybrid capture that you have mentioned. Is that hybrid capture only exclusive to Foundation One, or all the other panels that we have in the we have for NGS panels? Do they also use hybrid capture, especially when they say comprehensive? When they use the word comprehensive before the genomic profiling, do all of them use this hybrid capture, or is it only for Foundation One?
No, so hybrid capture is a technology which Foundation uses, but it is also being used by other laboratories, whether it is Caris or other which are FDA approved technologies. They also use for hybrid capture because of the higher sensitivity. And the reason which I was trying to emphasize was when a couple of labs in India, which they offer, they tend to go for PCR amplification based enrichment actually. So just for the discussion, but if you, there are a couple of labs which offer hybrid capture based technologies as a part of their comprehensive genomic profiling, not only Foundation.
Yeah, Amit, one question. In one of the cases in which you had discussed, mentioned like the patient had a T3 and pseudo colon cancer, and the patient was kept on follow-up and subsequently the disease relapsed. Do you think that incorporating the NGS technology at an early stage will help us to treat these patients much more earlier so that a relapse can be prevented in those group of patients?
Yeah, so I just mentioned you the case of collateral case scenario. There are various, which I mentioned, that KRAS or the RAS alterations besides the codon 12 and codon 13. That is the exon 2 and exon 3. So outside those things, we can identify that even the KRAS in early stages can also predict poor prognosis. So if you hit KRAS alteration in a stage 2 cancer or a BRAF alteration in a stage 2 cancer, you tend to be more aggressive, and which is should be the norm, which we are not following. But you will see that these patients will tend to lapse more. Do we change the treatment? It is a big question. But yes, as a physician and a group of physicians, a board can take a call. This is an exceptional scenario. A patient of stage 2, patient is young, and we don't want to take any chances. We would like to be more aggressive and get some adjuvant treatment. You can have a single agent capecitabine if you want to offer, but at least something should be offered rather than sitting idle and wait for the relapse to happen. But key factors are the RAS alterations in early stage cancers, BRAF alteration in early stage cancers, whether it is V600E or non-V600E, are poor prognostic factors which should be taken into account. MSI high, it seems to be a very good prognostic biomarker, which we all know. But if MSI high is because of the hereditary cancers, that is a Lynch syndrome, then they carry poor prognosis. So this is a subset of MSI high patients which may carry poor prognosis if it is because of the germinal alteration in the MMR gene. So because in our case, the patient had a family history of C. endometrium mother and also other family members, this was a classical Lynch syndrome. And being a stage 2, we would have expected to do good, again failed. So this is again exactly matching with the published literature. So we should be very vigilant with the MSI high and investigate further whether it is a somatic MSI high or a germinal MSI high actually.
So just by going with the by the histopathology and IHC, we could land ourselves in trouble. So it's high time that we start incorporating all this genomic data into day-to-day clinical practice. But then it's easily said than done because we don't have data on a day-to-day basis for that. So any other questions to Dr. Amit? Okay, so I think we'll go to the next session. So we'll be having 3 different cases. So 3 different scenarios, 3 different malignancies we'll be discussing. So Amit will be moderating the session. So first case is presented by Dr. Anthony. So over to you, Dr. Anthony. Anthony, you are muted. Kindly unmute yourself.
Yeah, I will share my screen. I hope my screen is visible.
Yeah.
Okay, so this case presented to me with a 58-year-old lady. She presented with a history of generalized weakness. She was evaluated, and then on examination, she was had a good performance status. Chest was clear. On examination of the abdomen, there was a hepatomegaly of 4 centimeters below the costal margin. Her CBC was hemoglobin was a little low, but other than it was normal. However, LFT bilirubin was 2.2, AST ALT was more than 3 times elevated. Alkaline phosphatase was also elevated. Albumin was on the lower side, 3.6, and PTINR also was mildly raised. Renal function tests were normal. So a PET scan was done, which showed a primary lesion in the right upper lobe, 3.9 into 3.8 into 2.7 centimeters. There was multiple subcentimetric lung nodules. There was an enlarged liver. It is a large contiguous hypodense FDG avid lesion occupying both lobes of the liver. So they kept it as a query synchronous HCC or METS. And IVC and hepatic vein thrombosis were also present. So this is the image. Image is showing the lung primary, and both the right and the left lobe of the liver was studded with METS. There was the large hypodense lesion as well as there was multiple smaller hypodense lesions. So we did bronchoscopic lung biopsy as well as the USG guided liver biopsy. Both of them were positive adenocarcinoma, and they were TTF1 positive. So we gave it as a diagnosis of metastatic CA lung adenocarcinoma with METS to the liver. In view of the impending liver failure, the patient was started on single agent carboplatin, and within 1 week, her LFT started showing improvement. At the same time, the biopsy sample was sent for the NGS panel. So it was a limited NGS. This was sent to MedGenome. They had a panel for lung panel of EGFR, BRAF, MET, RET, ERBB2, and KRAS, as well as fusions in AL cross, RET, and NTRK1. So all the relevant genes for targeted therapy were sent, and none of the genes showed any mutations. This was the initial report, but however, there was a side note in the report. The side note had shown that there was an EGFR mutation. It was an exon 19 insertion, not a deletion. Exon 19 insertion was there. But however, the mutant allele percentage, that was only 2.9 percentage. So the quality control according to the MedGenome labs was kept at 5%. So however, since it was less than 5%, they gave it as a report of variant of unknown significance. And however, the depth of reading the mutation was high, or 618 times depth coverage was there. So we were in confusion as to whether the 2.9% mutation is actually whether it is a lab error or whether it's actually present. So this is an exon 19 insertion, and it is susceptible to EGFR inhibitors, but data has shown that the duration of response is lower. And this was the issue. The allelic frequency was low, below the quality control, but however, the red depth was good. So now the issue was as to how to interpret the report, whether to treat it as EGFR positive or whether it is EGFR negative. And Dr. Amit, how would you like to comment on that?
Go back to the slides, please. The previous slides. Yeah. The slide number 9. Okay. So let's try to read the report in this scenario that the patient underwent a hotspot analysis trying to cover the key genes, which are perfectly fine, including the fusions as well, that is AL, cross, RET, and NTRK. And for the EGFR, the BRAF, the MET, RET, and the ERBB2 and KRAS, all of them are trying to pick up the point mutations as well as the insertion deletions, as well as the copy number alterations. So this is quite a good test in terms of the focused genes analysis. But if you see that the patient was not having any alterations, whether it was any genomic alterations which are approved by the FDA in terms of the target therapy with the FDA or non-druggable targets. When you go to the table number 3, go to the next slide, please. Yeah, so this EGFR variant of unknown significance tells that this EGFR, this alteration, whether this alteration is affecting the EGFR function or not. That is why it is called unknown significance. It is not based on the mutant allele frequency. So this is a wrong interpretation. So don't go by the allele frequency. This VUS stands for that this alteration which is picked up may or may not have the significance of EGFR overactivation, which we normally see in the EGFR alterated patients. So it is not like a standard DEL19 or IL-858R or T790M alteration, where the constitutive activation of EGFR happens. So this is something which I want to emphasize. So neither the lab nor the literature were very much familiar with this kind of duplication, where the location 740 to 745, this region was duplicated actually. Does it really apply? If you look into the alteration, this is lying in the exon 19 for sure. Now let's see the mutant allele frequency. So normally, if we were to assume that the patient had a good quality samples, and the normal quality samples of any lab is in the range of 20% of the tumor cells should be there before they can say the sample was adequate in terms of the tumor cells analysis. If that is the case, 2.9% is reflecting that very few cells or the tumor cells among the whole tumor block being analyzed carrying these alterations. If you have the mutant allele percentage to be less in this number for a solid tumor analysis, it gives you the idea that this is not being a driver alteration. Had it been in a higher range, I would have been more confident and I would have given some doubt, benefit of doubt, and attempted and considered to treat the patient based on the EGFR activation and then offer EGFR TKI. So let's give you a scenario that this whole test was done on the liquid biopsy and you had the similar results. And then in that case, 2.9 allele frequency would have been significant for me because there are so many variables where the secretions of the or the leakage of the DNA and the pickup rate of the liquid biopsy and the circulating-free DNA is very variable. So in that case, the VAF of 2.9 is significant. On the other hand, VAF of 2.9 in a solid tumor biopsy is not significant. So this is my interpretation of the whole report. I would not strongly jump and start treating the patient with TKI alone, assuming that the patient has EGFR activating alteration and stop chemotherapy. If I were to give the option, I would have tried or attempted with the combination of a TKI with chemotherapy or chemotherapy alone in this scenario when I was not very sure.
So I'll just tell you some things that I had with the discussion with the MedGenome technical team. Dr. Arun was there, so I discussed the case with him. So he told, the first thing he told was it's not a hotspot mutation testing that they're doing. They are doing the full sequencing of the gene. So they have a different hotspot panel, and they said that this mutation would have been missed if it was done on the hotspot testing. That was the first thing. Then second one was that there was like 4 blocks that we had sent for to MedGenome. So it had 10%, 20%, 30%, and 50%. So I'm not sure which block they've used for this testing. That is the second another aspect that they wanted to say about that. So does that make any difference in the reading of the report?
Yeah, so if the tumor percentage or block having less tumor percentage, then allele frequency will definitely drop down further because you are trying to compare the total genomic DNA and the tumor DNA. So let's assume it is less than 10% and you have 2.9% allele frequency, then you may expect it to be in the range of maybe 20% allele frequency if it were a 50% tumor cell block. So you can extrapolate that. So on the contrary, if it had been a 50% tumor cell block and you have muted allele percentage of 2.9, then it is truly representing only few cells are harboring this. and can be categorized as subclonal population, not a clonal population. So we are trying to identify a clone, which is the dominant clone, and expecting some responses if we treat accordingly. A subclonal alterations detection is very usual, not unusual to see. But if we act on it, you may get some benefit. But it is, to best of my knowledge, it is not worth attempting. But as I just mentioned, combining with chemotherapy will take care of the scenario of failure and can cover up our bases actually. So the ideal would be combining TKI along with chemotherapy in such cases.
So in this case, what we did was in view of that liver being started with meds, and we didn't want the risk of an EGFR TKI not working. So for this patient, we started her on TKI plus chemo. But another question I just want to ask is that is there any role of any repeating NGS from a different lab or anything at this point, or would it be better at progression?
So, well, this is a very subjective question actually. I would say that if you are confident with the lab report, I think I would have to stick with it. You have done the relevant genetic alteration, and that too was comprehensive. I would be more comfortable going and act accordingly. And this is, we know that certain tumors may have wild type scenarios. You may not have the driver alteration all the time. So not unusual to see. And trying empirically patient treatment, and as you already mentioned, the patient responded quite beautifully with the single agent platinums. I think you have good control on the disease. And if there was any progression, combining TKI with chemo, which you already have given an option, if it works, will give you more confidence on the lab report itself. So sometimes empirical treatment gives you a flavor within 3 to 4 weeks time if you can early assess the patient response and can give you some idea. I would not go for another lab test if I'm confident with what I have done actually. So I'm confident with the report, so I will not go for another round of test.
Thank you. And again, the PDL1 was 0% with SP142. So anyway, the immunotherapy option was not discussed. So we proceeded with EGFR and TKI for this patient. So probably after 1 or 2 more cycles, we will repeat the imaging and see, look for response and decide on further treatment. Yeah, and one more doubt I had. Yeah, and one more doubt I had in this case was regarding the variant of unknown significance. Why was this mutation mentioned as a variant of unknown significance? But there is already data in the literature that EGFR exon 19 insertions are susceptible to EGFR TKIs. But why was this gene mutations classified as a VUS?
So this is a very laboratory-based internal protocols, quality protocols. There are certain criteria what they try to lay down, not the VAF, which was mentioned by you. So mainly the classification of variant of unknown significance is based on the literature. If the literature is substantial, supporting the alteration, affecting the function of this gene, especially the activating, which in this case is, then they will label as driver alteration. Otherwise, when the literature is less, or they are not very sure of the in vitro implications of this alteration, they will consider to be variant of unknown significance, because they are not very sure that this alteration is leading to the activation of the kinase domain. So these are the literature where the laboratory own criteria, at what juncture they start saying it high or low, depending upon the level of evidence available. So this particular answers can be given by the laboratory per se, but you will always find few data sets or publications for all the alterations which you encounter. Not unusual to see, but should we act on it? That is a big question which we have to discuss actually.
Thank you, Dr. Amit. Sir Boban sir, if you wanted to add something, this is all just what I wanted to discuss regarding the case. Anything else specifically related to the case that you wanted to add?
Sorry, I was muted. Nothing. It was a good discussion which we had. So thank you. I think we'll move to the next case. Next is a case by Dr. Sanju. Sanju, over to you. It's good to have discussions like this. We are learning. There are all new things which were coming in. Sanju?
Go ahead. Yeah.
Yeah.
Hope my screen is visible for everyone.
Yes.
So thank you, Amit. Thank you, Anthony. It was a very good case. A lot of insights. I'm sure Amit will have some insights on my case also, because I don't think I had looked into those details in my report, and actually jumped into the treatment, which I think I will be looking into the the suggestions given by Amit. So my patient was a 55-year-old male patient, and he had periambulary carcinoma treated elsewhere in June 2016. He underwent a Whipple's resection, and post-histopathology was PT2N1, well-differentiated adenocarcinoma of pancreatobiliary type, and 1 by 12 lymph nodes were positive, and he was offered gemcitabine carboplatin-based treatment at that point elsewhere. Now, after almost 2 years, he presented, he had lung metastasis, and at that point, he was offered combination of irinotecan and oxaliplatin in a different hospital. And he was given the same treatment for 6 cycles, and the treatment PET-CT showed complete remission. And about 1 year later, he had progression. This time, he was offered 5-FE leucovorin, obviously because he's exposed to most of the drugs. And this time, he didn't respond to treatment and came to us for opinion. Patient did not give any significant family history of malignancy, but when I wrote down the clinical history, I was something was striking. Looking back, Gem Carbo after 2 years he failed. Then irinotecan and oxaliplatin he had very good response. He was not responding to irinotecan. 5-FE leucovorin. So I thought this is suggestive of a platinum sensitivity. So he underwent a repeat biopsy from the lung. One was to make sure that this is metastasis from the pancreatobiliary type of periambulary carcinoma. And the other thing was I wanted to do a next generation sequencing to see whether BRCA or other genes conferring platinum sensitivity were altered in that patient. So IHC suggested adenocarcinoma of pancreatobiliary origin. IHC for MSA was also done, which suggested microsatellite stable status, and the NGS was ordered. So this was the NGS report. So clinically relevant mutations were identified in ATM and PALB2 genes. So my concept was confirmed because this could explain why he had good response to platinum. And ATM and PALB2 both are mutations where platinum sensitivity is well documented. And this is the report what I got, ATM and PALB2. If Amit, I'm looking back to the previous case, that mutant allele percentage is mentioned less than 20%. So I don't know whether this is significant. And apart from that, there were some other variants also mentioned, ATM PMS2 and PALB2. But that allele percentage is now mentioned as 46%. So, Amit, your inputs? Yeah, mute. You're mute.
Just go back to the previous slide.
Yeah.
So very interesting case. A very interesting case. Periambulary carcinoma showing good response to platinums, and when we didn't use platinum, had a progression. And seen twice, starting with the Gem Carbo as well as the IROX treatment actually. So, and you have the answer here that you have a defect in the DNA repair pathway gene, and you have ATM as well as PALB2 as well as PALB2 other location alteration, but in the same exon 5. So this is very interesting. And let's try to see one thing at a time. So in this case, we have three alterations in two genes. ATM is one with the allele frequency of 11.5%. So, but this is an alteration. If you see glycine 2496TR is called termination, and there's a truncation of the protein, which is leading to the loss of function of the ATM protein actually. And this gene is not functional anymore in terms of function. And this is being implicated in the DNA repair. When this is affected, the DNA repair is affected, and you will see responses like platinum sensitivity. Now the tumor has developed another PALB2 alteration, which is again a termination alteration leading to the loss of function. And this is again involved in the DNA repair mechanism. If you go to the next slide, the patient also had PALB2 alteration again in the exon 5, very close to that location, 645. Can you go back? And this was 656. So they are very close alterations in the same exon of the same gene. So you have to understand that this particular scenario, if it is happening, so most of the time we know that the patient may have, there are a couple of scenarios here. So the first scenario, what I believe is that the patient have first hit on the PALB2 alteration at exon 5 and another hit on the other allele. And then the patient have this two allele being knocked out, and the patient had tumorigenesis, and the tumor developed, and the patient have this frank cancer actually. This is one hypothesis. The other could be the PALB2 one alteration was in the germline level, and the other hit was in the somatic tumor, and the tumor developed. So there are two possibilities. The third possibility is that the patient have ATM alteration as a germline, which is adding on to the PALB2 alteration, and all to coming together, which are low, you can say genes in terms of penetrance, but when they combine together, they are helping the tumor to develop. And both of them are synergistically acting in terms of going for tumorigenesis. So there are a couple of possibilities to decipher these things, these kind of scenarios when you have one gene with two alterations. The first question comes to my mind, whether are they cis alterations or trans alterations? When I say cis alteration, meaning that in the same allele, these alterations are present or not. If they are present in the same allele, then the one which is earlier, go back please. This is 656 and 645. So 645 will dominate, and the termination of the gene protein will happen, and there will be, this particular alteration will be useless. If it is a trans alteration that is coming in one allele and the other alteration is the other allele, then it is a double hit what we are seeing. In this case, PALB2 function is practically knocked out, and you will see the implications what we are seeing in this case in terms of tumorigenesis, and also in terms of response to platinum, and also in terms of response to PARP inhibitors. This is how I would like to read the report. And the possibility of one hit being in the germline scenario has to be evaluated by a germline test. But if I see the VAF, which is 12.8 in this scenario, I could predict that this patient does not have a germline alteration. This is the acquired alterations or somatic alterations. One hit followed by the another hit, which is causing all this trouble. And the PALB2 seems to be a driver alteration in this particular case. And I would strongly recommend a PARP inhibitor as a therapeutic option, as well as a maintenance option for the patient. So a germline test should be done just to be on a safer side, but my prediction says it would be negative. Now, let's go to the variant of unknown significance. And again, the patient is having ATM alteration, which is, they are not very sure whether this alteration is causing any loss of function. Similarly, PALB2 third alteration, which is again having a very high VAF, again showing a loss of function, they are not very sure. But if you see that the patient tumor analysis were able to pick up very high VAF, it reflects that the 8.1 alteration was primarily somatic or related to tumor cells only. And on the other hand, any alterations which are close to 50%, that is 40 is very close to 50%. So we can consider that these alterations are germline in nature. So this is a possibility that the patient have implications because these are very rare alterations, rare genes to be analyzed, and the data is not that great. This could be the first hit in PALB2 or ATM, and this could be the second hit in the somatic analysis. So various hypotheses can be generated to what is going and what is the early event, what is the second event. But the bottom line is the patient should respond beautifully to PARP inhibitor and to platinums. And if you are not confident, then titrate the dose of PARP at a half the dose and go on with carboplatin, combine them together to have the maximum benefit out of it.
Amit, what about the PMS2 mentioned there?
So PMS2 is known to be a pseudo gene, and as you have already mentioned, I think if I'm not wrong, the MSI was stable.
Yes.
So PMS2 is basically a mismatch repair alteration, which is reflecting the Lynch syndrome scenario. So if MSI is stable and PMS2 is altered, I would not give any significance to it. I would just leave it as it is.
Okay. Okay, good. So patient was initiated on gemcitabine carboplatin, but probably because he's exposed to platinum before, we didn't see a dramatic response. It was more or less a stable disease. He also had a brain lesion, for which we had given SBRT. So he was offered olaparib maintenance, and he has completed 5 months plus from the date of starting, and till now he has not progressed. He's doing good. So, like what you have mentioned, probably is responding to olaparib, but I have not seen an objective response radiologically. But there is a lot of clinical benefit from the day of presentation to our hospital. So this is about
So
my case.
I would say that please can you share with me the PD-L1 status on the patient?
No, I have not done the PD.
Yeah. So my prediction says the patient may have high PD-L1. You could check that because once you have this DNA alteration, sometimes the new antigen sometimes are higher in you can say percentage, and you may have some response to immunotherapy as well. So you will be ready for the second line option if the olaparib starts failing. But if you want to see an objective response and PARP inhibitor is well tolerated, just try with carboplatin low dose weekly AUC2, and you will see you can say response to the tumor as well.
Okay. Thank you, Amit. So it was a great explanation to all those alterations there. So probably for us clinicians, next time onwards, probably we look into those finer details as well before taking decisions on treatment. Thank you so much.
Yeah, thank you, Sanju. Yeah.
Thank you, Sanju. And in the next case, I am presenting. So is my slides visible?
Yes.
Okay, I have two cases. One is a GE junction, and another is an esophageal cancer. So the first patient is a 50-year-old man, male patient. He was evaluated for abdominal pain and found to have adenocarcinoma of the lower esophagus, which was extending into the GE junction, into the stomach. And there was a little bit of involvement of the inferior part of pancreas, which was a locally advanced disease. And surprisingly, the patient had a very large retroperitoneal nodal mass. So, in fact, the size of the node, the lymph node was more than 5 centimeters. So that prompted me to look for whether the patient has got two malignancy or whether it was a single malignancy. So I did a biopsy of the lymph node also. The lymph node also came as adenocarcinoma. So this patient, we started on chemotherapy with the float regimen. That's what we practice in our center. So there was a response. The nodal mass reduced in size symptomatically, the patient, which became much better. but then the surgical opinion was taken, and then surgery was not feasible for this patient because the surgeons felt that it has reduced, but then the reduction was not good enough to go ahead with an R0 resection. So we decided to give concurrent chemo radiation to the patient, but then the patient's tolerability to concurrent chemotherapy was very less. So patient was continued only on radiation. There also again there was further response. The nodal mass decreased further. Symptomatically, he was even much better. So that time we discussed the option of surgery again with the patient. The surgery consultation, GI surgeon had seen the patient, but then they felt that okay, surgery will not be able to could not be performed because an arterial resection was not possible. So we decided to change the regimen, and then by this time we decided that okay, we'll move to a palliative intent. So the patient was started on EOX regimen, and patient was again continued. Patient continued to have clinical response, but then surgery was not feasible. So, but then patient was having very good performance status. They were insisting on continuing the treatment. So the other options which we kept in mind was gemcitabine, and then it was planned to initiate the patients. For that time, the options we discussed vary because the patient was clinically doing fine, but then the kind of response, the presentation itself was a little bit vague. So we thought we will do a sequencing test for this patient. So I'm sharing the report. This was the report which I received for this patient. So all these genes were found to be amplified or mutated. So Amit, how to proceed further based upon this result if we are getting?
Yeah, so very interesting case, and I would like to ask you: did you ask the patient to undergo HER2 testing?
HER2 was negative. HER2 was
it was negative, and
yeah,
PDL1 was also negative. I assume that.
PDL1, yeah, PDL1 was also negative. Both HER2 and
Okay,
PDL1.
great. Okay, so now we have these 4 alterations, and these 4 alterations, we understand T53 is the commonest one, so nothing unusual to see. And cyclin E1 is again a cell cycle dysregulation, and PDGFR is again required in the vascular, you can say, alterations or vascular or angiogenesis. So if you see out of these 4 alterations, the one which comes out to be very significant to me is the PDGFR beta. But unfortunately, the amplification which they have mentioned is 2.5 times. So when I say 2.5 times, that normal a cell have 2 alleles, so 1 and 1 is always there, so 2 is always there. So having a 0.5 increase in the genetic level, does it really apply that whether this patient will have PDGFR based signaling? So this is something which is questionable. So we should not always just go what the report says and just see the drugs which are written on the report. This is the amplification gives you a good idea of whether this is a significant alteration or not. The one which is significant is this. And if you see this alteration, which is having 62.97% alteration, this is a significant alteration actually. And then we know that T53 cannot be targeted very easily. And now we have the drugs called V1 inhibitors, WEE1 inhibitors. And the drug which is being mentioned in cyclin E1, that is adovasertib, should be used for P53 alterations here. So adovasertib with chemotherapy is an option for these patients, knowing the fact that the patient is not responding to the conventional treatment based on the TP53 alteration. So this is the take home which I would suggest. I would not go with immunotherapy or everolimus or Volfox based on the TP53 alteration. I would be little skeptical of using drugs like regorafenib, which is a very strong drug with the amplification of 2.5 times. If I were to combine any drug which is affecting the angiogenesis, I would be comfortable using the drugs like sorafenib, which have PDGFR beta action at a lower dose, along with the chemotherapy. But if adovasertib is not available, then chemotherapy along with angiogenic inhibitors like bevacizumab should be an option for this patient actually.
Thank you, Amit. So just what you're saying is that just because we get an amplification and a gene has been mutated, that does not mean that we should be starting the patient immediately. It should not be a knee-jerk reaction. We should look for the percentages, all these things, and then only take a call.
Yes, yes.
Okay, thank you. I have one more patient. So this is another lady. This is a 62-year-old lady. She was evaluated for dysphagia and was found to have a locally advanced mid-esophageal squamous cell carcinoma abetting the carina. Then she was a lady who underwent a bariatric surgery years back. So then the surgical option was very difficult because that's what the surgeon felt, because already a good portion of her upper GI was removed. But then this was also a locally advanced case. So the patient was subjected to concurrent chemotherapy, followed by 2 cycles of adjuvant chemotherapy. And she had a very good partial response. Clinically, she became better. Radiologically, there was a partial response. But then there was a paravertebral fluid collection. Everything was there. We couldn't, that an endoscopy was done. And we ruled out a esophageal pleural fistula. This fluid was aspirated twice, sclerosant was injected, but then it kept on recurring. Then we just ignored it for some time. Then she developed a chest pain, and then the CT scan showed progression with metastasis into the ribs, liver, multiple lymph nodes, pleural effusion, and she also had an inguinal node. So the family was very insisting on doing something new. So the patient sample was sent for mutation analysis. So this was the report which we received.
Yeah. So a very interesting scenario. Though the patient is 60 years old squamous cell carcinoma and having BRCA alteration, and this, if we try to read this alteration, this is at a location called 671 minus, means just at the boundary of exon and intron at -1, that is towards the exonic, not toward the intronic region, and there is this translocation. And this alteration can be predicted to be a splice site variant. When you have a splice site variant, the intron exon does not splice properly, and unnecessarily the intron is being expressed, and then you have altered protein. So this may have a significance in terms of some actionable alteration, which I would say. But if you try to read the quality of the report in a VAF category, they have just mentioned heterozygous. This is very confusing for me. I would love to see a percentage here to be confident whether I'm dealing with a clonal alteration or a subclonal alteration. If it is a subclonal alteration, then again, my choice based on BRCA1 would be a futile effort. But if it is a clonal population, then I may expect some responses. And again, the MYC amplification is only 2x, 2 times. So again, not a significant amplification. But on the other hand, the patient have FGFR4 alteration with a very high percentage in VAF. So this is a dominant, you can say, alteration. And if BRCA is also having high VAF, so these are the 2 drivers which we are dealing with right now, which we can say one is in the DNA repair pathway and the other is in the vasculogenesis pathway or angiogenesis pathway. So this patient will benefit with the anti-angiogenesis approach or approaches where the patient may get benefit by using the FGFR inhibitors directly. And if you see that the report has mentioned adafitinib, which have a direct effect on the FGFR4 alteration. On the other hand, pemigatinib, what they have mentioned, does not have that significant effect on the FGFR4. It has been normally recommended for FGFR1, 2, and 3, not for 4. So this is quite a questionable thing for me as well. Anolitinib, on the other hand, not available in India, available in the Chinese continent, where it is against VEGF as well as the FGFR. This is also a good choice. But again, accessibility is a problem. But we have to investigate further and ask the lab to give some more answers whether this BRCA1 alteration is having high VAF or not. And now if we see that the ATRX alteration with a VAF of 7.4, which is more than 5%, so it is probably a clonal alteration, but not present in all the cells. This also reflects that the patient may respond better to PARP inhibitor. So BRCA1 and ATRX combining together gives me a flavor that the patient have a PARP inhibitor sensitivity at the same time. And now if I see the NF2 here, NF2 leads to the activation of the mTOR pathway, which is seen here as the temsirolimus is given for as an actionable scenario. But if we were to treat this patient highly on a combination therapy, and if I were to make a call on this patient, I would have used PARP inhibitor with mTOR inhibitor. And there is a synergism which has been reported in the literature where inhibiting the mTOR pathway and combining them with PARP inhibitor have shown to enhance the response. And then combining the third drug, which is the anti-angiogenesis drug, can be an option for the patient if the BRCA1 alteration is not that significant. Then giving erdafitinib would be a good option for these patients. That is my take home for this particular case.
Okay, thank you, Amit. Thank you for that excellent interpretation of the data. Any questions? So, Amit, my general question is like, how will you decide upon what test to be done for the patient? So, day-to-day clinical practice, we come across multiple companies coming up with their own technologies. And as a clinician, we are not that well versed with all these technologies. They say like, okay, they are sequencing some 300 genes. Other companies will come and say that they are sequencing 500 genes. And other people will come and say that they're sequencing other 600 genes. So how as a clinician, how should we decide on what should be the best test that can be offered to that particular patient? I know it's a difficult question, but
yeah, it's a difficult question. It's a difficult question. And the bottom line here is that I can give a small lecture on the key criteria which are being offered, which are being standard of care in terms of the diagnostic testing. And it has been given by the College of American Pathologists as a guideline what to look for in a laboratory working environment in terms of the criteria, the positive predictive value or the sensitivity or the limit of detection, and a lot of validation data, what they normally do. So, so the bottom line is that you can ask the lab to submit you the validation data for the assay what they're offering to you actually. And the validation, just to give you an example, for each gene to analyze, they have to have almost 60 different patients having similar alterations before they can say this is a truly validated test actually. So this is not an easy test. To best of my knowledge, majority of the labs fails the criteria which is being laid down by the College of American Pathologists as a validation. And Foundation have the most robust data to best of my knowledge with the 6,000 patients clinically validated, and that led to the FDA approval. So FDA approval is not just a stamp, it is a truthful validation done by the foundation based on which the confidence is built up. So, but as we are limited with the cost constraints, issues are always there. We have to make a choice. And sometimes we try to compromise on the options of not going for the FDA approved test. In that case, you can ask the lab to submit with you the validation data, whatever they have. And then you can compare the validation data of different labs, and then you can build your confidence on each lab where you want to follow. And then once you start offering the test and focus on a single lab, you will see the alterations picked up by the lab if they start translating into the clinical benefit of the patient. then it is the true alteration what you are putting, and that is the clinical utility of the laboratory alterations. So once you see that as a life cycle of a test, if that is coming out to be good, then the confidence is certainly high for that lab actually. That is how what I do and what I have learned over. It is not a single week or single month experience. It is over the years what we have learned that this kind of limitations can be seen in this particular lab and not the other alterations. So I can just seeing by the all type of alteration, I can predict was it a limited validated alteration or a exhaustively validated alteration actually. That will give me a confidence.
Can I add something? Just Dr. Nip on the side. So all just to maybe build on to what plus one to what Dr. Verma said, but also there are two additional concepts. So one is that in most of the labs, generally they'll say that they are CLIA CAP accredited, but lab accreditation of CLIA and CAP is not the same as the test being validated by CLIA and CAP. So just wanted to add that part as well. So while there may be reports mentioning CLIA and CAP accreditation for the lab, but that is a lab accreditation. For test, there is going to be a separate recommendation. So these are two separate things, should not be confused.
Yeah, Amit, one more question. Sometimes what will be the best sample, whether it is blood or the tumor tissue, to do all these tests?
Yeah, so again a very important discussion. If you were to get a liquid biopsy done for any of your patients, the laboratory validation for multiple genes on liquid biopsy is a big challenge. So most of the laboratories, if they are offering a liquid biopsy analysis, they are 1 gene, 3 genes at the max, and sometimes they claim that they do 48 gene analysis. But liquid biopsy is a very tricky test in itself, especially when you are expecting any fusion gene. Let's say if you were to pick up ALK fusion on a liquid biopsy, the chances that you may fail is quite high. If you were to pick up copy number alterations, chances that you may fail is quite high. So if it is what you suspect or what you expect, liquid biopsy has some limitations. On the other hand, few labs have validated their sensitivity on the copy number alterations as well as fusions like anti-RP fusions and all. And they have a quite good sensitivity similar to the tumor analysis what we do on the FFP block. So those assays give you a robust data, can be attempted. But in my clinical practice, I always prefer and recommend FFP block as my source of information because the variability is less in terms of the technical variability. In terms of the tumor heterogeneity, definitely liquid biopsy supersedes the tissue biopsy analysis. But when it comes to the real experiments in the lab, tumor biopsy analysis is much easier and much reproducible as compared to the liquid biopsy. So again, not a simple answer to give.
Thank you, Amit. Any other questions? Okay, if there are no other questions, I think it's already past 9 o'clock. So thank you, Amit, on the behalf of AMPOK and my personal behalf. It was very nice listening to you, learn so many things, but then I know that it's just the beginning of a long curve. We need to study more. We need to interact with people who knows it better. And that, but because once you start reading all this data, it just goes always above my head. So it's always nice that somebody teaches it. Your talk was always like a class than of a lecture kind of a thing. So on behalf of AMPOK, very thanks once again. So definitely we'll be inviting you more for these discussions. So I hope you will accept our invitation. And I would like to thank Roche and Foundation Medicine for this opportunity and for the support extended. So this is a new concept which we started, and I hope we will continue with this so-called molecular tumor boards in the future also. Thank you, Amit.
Thank you very much. Thank you very much.
Thank you, Dr. Amit. Thank you,
Yeah.
Dr. Boban.